update every number 14.
So welcome to our report out for RPIW number 14. You can see here our agenda and the order of which we'll go through our presentation for you today to a tack time of 20 minutes. So I'd just like to introduce you to our team. First, you can see we have Dr. Rye, who's a physician in Prince Albert, and Tammy Gillis, who works in the emergency department. Tanis Thompson works at the Victoria Hospital. Pat Stewart from Quality Management. And we have Cheryl Elliott from our finance department. And Taylor Bassingwaite from our Kaizen promotion office. Dr. Stein from the emergency department here in Prince Albert. Myself, Stacey Smith-Coleman from Quality in the health region. And of course, Audrey Zwack is our patient representative, and she's also from Prince Albert. So our project was to reduce the lead time for CTAS 3 patients from triage to physician. Our sponsor was John Pickett. Our process owner is Dr. Colin Gallons. I'm the team lead for this project, and Tanis Thompson is our sub-team lead. We had Taylor Bassingwaite as our Kaizen support, and Sensei Narita as our John Blackman Associate Consultant. Other departments that were involved were Lori Bolotniak from IT, of course maintenance, and as well Terry Field from housekeeping was instrumental. So our current situation was such prior to our RPIW where 58% of our patients who were CTAS 3 were waiting greater than 1 hour to see the physician. And CTAS is just a scoring of acuity level. Our CTAS 3s, the goal is to have them seen by the physician within 30 minutes. And so we weren't meeting that. We also know about 8% of our CTAS 3 patients were actually leaving the department without seeing the physician. CTAS 3 patients are of particular concern for us because they can deteriorate quickly in the waiting room as if their condition deteriorates, obviously leaving them at risk of harm if they're not seen quickly. So our goal was to get our CTAS 3 being seen within that national guideline. So I'm just going to tell you a little bit about the state prior to our improvement work. I'll just highlight the inventory that we found in exam room 5. A total of 331 items were in there, and we had a goal of reducing that by half. Our ER physician was walking about 573 feet per hour. Again, we wanted to try and reduce that by half during this week. Our glucometer traveled about 233 feet per hour, and we wanted to see if we could get that down by half as well. The glucometer was a concern because as we were observing our triage nurse having to do blood sugars on patients that she was triaging, a lot of her interruptions had to do with searching for that glucometer. There was only 2 in the department. So just to highlight our 5S score for exam room 5, prior to our event week this week, it was a 1.4, so that's low and that's not good. We wanted to see it increase to a 3. And our capacity as well, we measured the number of patients seen by the physician per hour, and we had an average of 2 patients per hour, given the amount of time that physicians, the ER physicians, had to do their work and the amount of work they had to do per patient. And we wanted to try and increase that to 3. So this was our pre-Kaizen value stream map. And as you can see, our total lead time, which we measured, was from when the patient began triage to when the physician actually assessed the patient. So we can see that lead time was just slightly over an hour. So what was happening is it was taking about 10 minutes for the nurse to work through her triage. And then the patient was most often put in the waiting room, and they waited there for about 35 minutes. And then they were brought into the department and sometimes waited there for almost 17 minutes. And then the physician came. So you can see we had a lot of Kaizens that we worked on this week, and the value added for the patient was only 17.09, and the non-value added was about 83%. Yep. And some of our PQA data was that on average, 71 patients are being seen in the emergency department per day. And of those 71 patients,
23 of them are a CTAS 3, and we have 17 physicians that do work in the department. So that is how we looked at our PQA data, and we calculated our TAC time. So we know that the physicians have to see a patient about every 20.28 minutes to keep the flow going through the emergency room.
So we did our 5S this time on exam room 5, which is the ear, nose, and throat room. And although it's a specialty room, it does need to work for everyone. So as you can see, pre-Kaizen, there was excess supplies overflowing to the tops of the cabinets on the wall, over top of the countertops, and the drawers were quite full to overflowing. When we were evaluated pre-5S, our score was 1.4 out of 4. During the 5S, we removed 193 items that were either not required or excess in the room. These were made up of more than $196 worth of supplies, some excess sterile equipment and kits. We also found a few pieces of antiquated equipment or parts thereof, and some of the items we removed were actually considered hazardous. Post 5S, there is up-to-date labeling indicating the quantities of medical supplies required. Supplies used regularly were put on more accessible areas for the providers. Drawers are labeled on the outside and on the inside to help with finding items and restocking. Our evaluation post 5S was 3.7 out of 4. We also created standard work for restocking the medical supplies. And of course, with any new piece of standard work, we have created a multiple skills training form, checklist to track the training for this work.
So one of the things that we started was observing the physician's cycle time. How long does it take for the physician to do the work that he needs to do? So pre-Kaizen, we broke the physician cycle time into 2 different cycles. One of them is the initial assessment cycle, and the second one was the review cycle. Our initial assessment cycle showed that on average it took 12 minutes and 34 seconds for the physician to get to his initial assessment. The second part, the review cycle, was 15 minutes and 26 seconds for a total of 28 minutes of total cycle time. And as you can see on our standard work combination sheet, that our TAC time of 20 minutes and 28 seconds is not being met. We are 8 minutes over, which means that we are not being able to have those patients cycle through as they need to be in the department. If you look at the percent load, you can see how there is probably about 30%, 25% above that TAC time line, which shows that we need to reduce that timeline for the physician in order to be able to see the patients in the appropriate times. One of the drawbacks to our department is, that we see with our fast track room, is that this room is not facilitated by patients in wheelchairs. You cannot get the patient into the room and close the door. That little table, which becomes a place to store things, was identified as being a barrier to getting those patients in and out of those rooms.
So we came up with 2 ideas to speed up things. Firstly was to remove that table altogether out of the ER. That's a small item. And then a bigger item was to move the ER physician, when we have 2 in the department, closer to the triage with his own working station, so that it is a shorter distance to travel between triage and the rooms where he's going to see the patients. If you look on the pictures, there's the desk gone, and now suddenly you can put a wheelchair in there and close the door, because this room, if there was a wheelchair patient before, you had to wait until there was a room open for him. Now we can actually quickly see the patient in that room. There's our chief, Dr. Gallants, seeing a patient at the new mobile station, right by the triage room. That light you see in the background, that's the triage room, and which will speed up things significantly. So what we did, on the next page, we created some standard work for the physician, and this is when the second physician comes on during the day, usually 11 o'clock in the day. You will review the labs from the previous 24 hours, physicians not in the department like before. Then he'll log into that working station, which is now right at the triage department, and then If there are no CTAS 1, 2s or 3s in the department, he'll grab a chart directly from the triage nurse on a predetermined area and preferably see that patient in the fast track or exam 1. Once he's done with that patient and gave the orders to the ward clerk or to the other nurse, he'd go back to step 3 there again, and once again, if there's no 1, 2 or 3, we'll repeat the process. So if we then look at the time observations, the doctor's cycle decreased to quite a bit, to 15 minutes prior to seeing the patient and 12 minutes seeing the patient. We have to admit that this specific day that we did these time trials was a fairly slow day, and there are numerous other variables that you cannot control. Looking at the standard work combination sheet and the percent load sheet, the ND now makes the tag time. The multi-skilled sheet, the 5 doctors in our department were already orientated and familiar with the process, and we're comfortable that the rest of the group will be by March the 3rd.
Having looked at what happens inside the rooms and the doctors actually coming to the rooms, the next thing we want to show you is what happens with the triage nurse and the initial assessment of the patient. Due to previous RPIWs, we found that there were very few non-essential interruptions happening to the triage nurse, that interruptions were due to talking to people either face-to-face or on phone calls or in terms of getting equipment. And although the getting equipment was rarer than talking to people, it lasted considerably longer. In particular, we want to show you what happened to the glucometer. We felt that the glucometer was actually moving around far too much in the department. It moves for guys about as far as a football in an average hour of football play, or about as fast as a bride moves down an aisle. By getting another glucometer, which is actually free because we pay for the sticks and not the machines, both the movement is decreased, we save time in terms of getting the machine, it's available for when ambulance cases come through, and we found we couldn't eliminate moving the machine due to calibration issues and emergency issues with CTAS 1s. And there was increased safety because we weren't moving a potentially blood-stained piece of equipment around the department. Therefore, I'm going to pass on and we're going to talk a little bit more about what we're doing in terms of keeping things clean, in terms of other initiatives.
Our assignment in this project was to explore how changes in environmental services procedures might lessen the time moving CTAS 3s through the ER department. On our gamma walk, concern was identified with the inconsistency of communicating the need for infection control protocol to the environmental services worker. There were plastic sleeves on the door of the examining rooms. However, those color-coded sheets were not right at hand and were not being consistently used. So the situation was the environmental services workers, leaders, could go into those rooms and not be protected for knowing in advance that it should be an infection control protocol. The change we made was the 6 infection control precaution sheets were laminated, put on a ring, and hung on each of the doors of the examining rooms. There's no infection control precautions required. The blank side shows. If infection control precautions are needed, in place, the nurse flips the sign, the appropriate precaution, hangs it back on the hook on the back of the door, easy. Now there's no looking for precaution sheets. They're right at your fingertips. They're laminated for durability and easy cleaning. It's very important for the safety of patients and staff, as they may need personal protection equipment prior to entering the room. A standard work was also developed for this process.
To
patients is optimum. It's really important to know when an emergency room has been cleaned and is ready for the patient. When a patient room has been cleaned, the environmental service worker notifies the unit clerk to change the indicator on Sunrise Clinical Manager from the housekeeper, which Stacey is pointing to, the ivy green color, to ready, which is the leaf green color, indicating the room is ready for a patient. Sometimes it takes the unit clerk a long time to change the SCM to ready, and this delays a patient getting into a room. So what we decided to test was to ensure the Sunrise Clinical Manager indicator was ready as soon as the room had been cleaned. We were going to have the environmental services workers actually do the inputting into SCM themselves. We have started this process. We've had a network account created for the environmental service worker, but as all of you know, it takes a little while to get IT completed, and so we were not able to complete the test this week. But what we'll do in the next few weeks is have the environmental service worker trained on the system, and then she will be inputting the ready. We've also developed a work standard for housekeeping, as each department in the hospital is very different, and there are different needs that need to be met. And we also develop standard work for a quick cleaning process, which of course isn't done until after the room has received a thorough cleaning.
So this was our, at the beginning of the week, our waste wheel and the walk that we did through the department, and we identified all the waste that we could look at and potentially use as Kaizens. And at the end of our week, we were able to do a few Kaizens and eliminate some of the muda. This is our new CTAS patients from triage to the assessment. And so with triage taking about 9 minutes, and the patient waiting about 6 minutes to see the physician and then the physician. So it was a decrease of 75%. However, like Dr. Stein said, we do recognize that it was an extremely slow week, and the notifications for please don't come to emergency were also playing on the radio. So we realize that this will be a really hard standard to maintain.
So I'm just going to highlight some of our most significant improvements that we made during the week. We saved a little bit of square footage by eliminating some of those really high up items on those shelves, ones that weren't reachable anyway, and they were all covered in dust. So we had a 20% reduction in square footage of exam room 5 for the counter and shelf space. Our inventory in exam room 5, Cheryl gave you the details, but that equated to a 58% decrease in the number of items stocked in that room. ER walking distance for our physicians, it went from 573 feet per hour to 463 feet per hour, so we reduced that by about 19%. And our glucometer, Dr. Rai told you about that project. That was a reduction in 88% travel distance for that glucometer in one shift. So our overall lead time, as Tanis just mentioned, our physicians from triage to, or our patients, the length of time from triage to physician assessment was a 75% decrease in this. Tanis and Dr. Stein have both mentioned, we know the change is an improvement. We don't know if we can sustain that much of an improvement, but we're very hopeful, and we know we're going to continue to work on that initiative and help it move forward. Number of patients who left the department without being seen during the week, we saw about a 25% reduction as well, possibly due to some of our work, but maybe not. So exam room 5 went from a 5S score of 1.4, which was a 59% improvement. Our newspaper item, we have a few things left to do. Of course, our training. We're going to try and continue to work on how long it takes our physicians and nurses to have to log in, the amount of time that they're logging in during a shift. And of course, one of the other ideas was a do not disturb sign for our triage area, and we're going to test that again as well. We'll just have to do it in another week.
So workshop summary, we found it's a challenge to sustain and build on the improvements that were made, that everything's interconnected, and it can make it really hard to focus on your little task at hand. It was inspiring. Watching the providers of care, take the ideas and run with it, call them a wow factor, we learn don't be too quick to disregard the ideas that seem impractical. And no matter how many mistakes you make or how slow your progress, you're still way ahead of everyone who isn't trying. So thank you to Sensei, to Machiko, to Dr. Gallons, Dr. Wessel, Dr. Smith, Dr. Thun, the ER staff, the maintenance staff, Terry Field, Tracy and the other Enviro Services workers, Lori Bolotniak at IT, Deb Dollar, Brad in printing, and Audrey in ER.